Thank you very much, and what a great talk and lovely way to lead on. Thank you. I'm a chest physician, still clinically active, but also doing research, and based in here in Leicester. I'm going to talk about acute care research. Now, acute care research, I can talk about bits that we already do really well. So we've got lots of studies in myocardial infarction, stroke, intensive care. But actually, those of us that are still clinically active will know that that's not the vast majority of people that come through our hospital. The vast majority of people that come to our hospital now are older. They tend to have chronic conditions. And if you have a chronic condition, we know that you're 50 or multiple long-term conditions, you're 15 times more likely to end up in hospital and spend a lot of the time in beds. So I was on call at the weekend. Everyone I saw had a chronic condition. We had wards full. We had ambulances, despite it being Wimbledon, which is meant to be our non-winter pressures fortnight. We still had people waiting in the back of the ambulances to see us. And it was a chronic conditions that they all came into. So there's very little research done in this area, and I want to talk about that. And it's an area of huge inequality. We had a great session this morning talk about inequality, but I'm going to talk about a different, almost hidden inequality that we see. We know that people who come into hospital and are admitted are not the ones that get into research. As I say, was on this weekend. Not one of them will have been in a research study. And the reason for that is that they aren't the people we see in clinic, and they aren't the people that volunteer and come and see us. We know, this is work that we did, that they are more frail. If you're in hospital, about 60% of the patients are either pre-frail or frail. They are not robust. So they can't come and see us, and they struggle to come and see us. They are also from the most deprived areas of the country. Money is a difficulty. And this is one of the reasons I love respiratory medicine, is I feel I can be a voice for people that really don't have a voice. I'll talk a bit about my particular interest in that. But so as well as that, they might be unwell. And we know that once people are in hospital, they come back in. There's this awful phrase of revolving door patients, which is awful because it makes it sound like we can do something that's their fault. It's not. But they have this cycle of readmission and discharge, and they don't come and see us in clinic or see the specialties that they need. When we recruit patients, these are patients with multiple conditions, they often hit exclusion criteria. And as many of you know that speak to them, there's increased confusion and delirium, particularly in the acute state here. So I'm going to use an example and a study that we've done on something called chronic obstructive pulmonary disease, or COPD. And when I give my normal talks, I don't need to introduce this because everyone knows what it is. This is a disease of breathlessness and flare-ups, or what we call exacerbations. In the UK, particularly caused by smoking. For some reason, that makes it hidden, even though myocardial infarction is a smoking-related lung condition. Why are we not fussed about COPD? But actually, it's the third largest cause of death worldwide. It's the fourth biggest cause of disability in the UK. Yet 80% of the public have not heard of it. I suspect many people here may not have heard it unless you've done medicine. Yet it's a huge bit. If ever you've been a junior doctor on a ward or been a nurse on an acute medical unit, you will have seen patients with it, though, because it's the second biggest cause that people come into hospital for a medical reason. And actually, it now is the biggest cause of readmission to hospital that we see. So when a patient is admitted with an exacerbation of COPD, 1 in 2 of them are back in hospital within 3 months. 1 in 8 of them are dead within 3 months. So we have coronary care units, my cardiologists have all sorts of resources, yet we've got 3 times the mortality rate in my patients that we see with COPD than we do with myocardial infarction. So just to go back to it, so it's a really important disease. And actually, I qualified this month 20 years ago in medicine, so I'm 20 years qualified. And 2004 was a landmark year for the treatment of COPD, not because I qualified, sadly, but because it was the last time there was a new drug licensed for COPD that we treat patients with. There has been no new drug for COPD in the entire time I have been qualified in medicine. And I used to have hair. So we got excited. because there is something called biologics. These are monoclonal antibodies, and we use them in asthma. And, you know, in case you're into industry and things like that, it's a really big market. It's currently worth $6.6 billion worldwide, and that's, in asthma alone, is going to go up to $19 billion in the next 10 years. It's huge. And there have been some moderate trials in COPD. Early results less impressive, and I think we'll have the first new drug licence by the end of this year in respiratory disease. I'm currently battling and negotiating with NICE on advising them to see if we can get it through. How far that will get, we'll see. But it's designed to reduce exacerbations. So we all got excited because it reduces exacerbations by 30%, which is massive. But actually, in a lot of our populations, what that means is that you need one less course of antibiotics every 2 years, which I would argue is not a massive clinical impact. However, what happens if it could reduce people hospitalised? What happens if we could reduce all these hospital admissions, when we talk about winter pressures? These are my patients who are struggling at home. So I'm going to introduce you, because I'm sure not many of you have gone into the town centre for Leicester whilst you've been here for the CRF. I'm from further north, and I still rarely go into Leicester city centre. But I'm going to introduce you to Glenfield. So Glenfield is a cardiorespiratory hospital on the edge of town, and we are responsible for all cardiorespiratory admissions that come through Leicestershire, so about a population of 1.2 million. And we still man the front door, which is great, but also means that people who are clinically and research active are able to do research. So we've got this huge experience of doing research studies in the area. So I, as part of my PhD, did a 400-person rehabilitation trial between here and Kettering, which is it's our local district general. It doesn't do a lot of research, but still recruited 200 patients. We have done some breathomic studies, which is very clever and got some good diagrams that I don't understand. And we've looked at frailty and sarcopenia. So we have got this huge experience of fairly lifestyle-orientated research studies in there. But we're interested, this is a CRF conference, so I'm going to talk about early phase drug studies. And with biologics on the horizon, we approached GSK and said, you've got this drug mepolizumab. It looks pretty good. We think your phase 2 is going to be negative, but if you give it to an in-hospital population, this is the population you want to target. And they said, yeah, maybe. And then the phase 2 trial came out and repeated exactly what we said. So they agreed to fund us, and we aim to recruit 240 patients from a single centre in 18 months to this study. To put that in context, when we talked about this, one of my respiratory colleagues at another BRC said, who's an asthma consultant, said, well, hang on. No one recruits more than 3 or 4 patients to a biologics trial per site. I don't know with how many trials you do, but yeah, 3-4 patients maybe. What are you doing recruiting 230? And we said, oh, we can do it. And then we got green light March 2020, and something got in the way. But we'd had set up this research on other topics. We were ready to go with this trial, and COVID hit. So what did we do? We recruited to COVID. And any of you that will have heard of Leicester will probably have realised we did really well in terms of recruiting to COVID. So for the recovery trial, we recruited the highest number by quite a way in the country to the recovery trial. We were name-checked about both in the BBC News by the recovery team. And in fact, when the recovery team were FDA investigated for looking for approval, they came to Leicester to investigate it because we had all the patients to look at. So we were able to take our experience from what was going to be the COPD HELP trial and immediately translate it into recovery. So we were there ready to go. So recovery has been, we can demonstrate that we were there and ready, and that's why recovery was successful, because we had the infrastructure in place. So back to the COPD HELP trial. Well, COVID got out the way. We also did other bits, and we recruited. And we have now successfully recruited last November all our patients. We had our last patient last visit last month. From that, this is now the largest single-site biologics trial in either asthma or COPD in the world. It is also the largest single-site inpatient drug study in asthma or COPD in the world. And so we've, just to demonstrate that you can deliver acute inpatient trials, early phase, so phase 2 biologics, not just other trials that you can do, but it needs some lessons. So here's the lessons that I've got. Firstly, patient pre-screening is important. But we've got electronic healthcare records now. When I did it, I used to go around and look at the books on the wards. But now, my fellows were sat on their chair in the morning looking at health records, screening. Now, the biologics trial, I won't go into in huge detail, but 2/3 were automatically excluded based on a blood eosinophil count because we were looking for a particular phenotype. So we were able to screen them out. So we, just at the computer, were able to see that about 800 people were eligible out of 3,000 admissions. We then approached them and we could see that probably about 600 out of those 800 were still eligible. And actually we recruited nearly half that we approached. So this is the kind of pick-up rates that are incredible for studies. It's unusual to see someone that you approach de novo, say, are you interested in research for this trial, to pick up. We had a nearly 50% pick-up rate from that. But there are other lessons to learn. Staff models are really important. Where we work, there's no such thing as one study, one nurse, or one healthcare professional. They are signed up to multiple studies because it's highly variable. Inpatient trials, someday you'll have 0 patients. Some days you might have 2 or 3. It's always Friday that you have 2 or 3, isn't it? So we have to have a flexible model so people can go, look, phone up, got these patients, let's go, let's dose, let's get the measures doing. And I cannot emphasize the multidisciplinary work. And we have medical staff, we have nursing staff, we have physiotherapists, we have non-medical staff, lab staff, all working together, and it's genuinely multidisciplinary. There's no hierarchy whatsoever. In fact, I can tell you exactly who actually ran the study, and so can my fellows. They were driven to it, which is great. You've got to work with clinical services, and actually there's real pride. When I talk to my clinical services, they love talking about this kind of stuff. I work at Glenfield. I'm on the front door. I help deliver this study. But don't make them do work. It's pretty busy on the front door. I don't know if anyone's read the news. It's really busy. So they can't screen for you. They can't pick up and phone up and whatever. But they can go. You can go to them and say, have you seen anyone? Have you got anyone? Are you happy for me to approach? And they'll go, yes, of course they are. So do work with clinical services, but don't burden them more. The last thing I'd say about inpatients is that, and I use this word completely deliberately, they are a captive audience because they want to go home and they're stuck in hospital. So they are captive, and we've got to be very, very careful about that. We've got to speak to people, but actually they want to help, and if we can try and approach them, we can do. Key to that is the discussion with the patients and the families. It often required us contacting loved ones, partners, families to explain it over the phone. There are practical things. There was something about, I have no concept of this. Book a taxi. Putting costs for a taxi in your grants for this. Patient transport without offering a taxi isn't going to work. You've got to be flexible around the patients and what we can do. And they've got to be willing to come back, and we've got to be willing to work around the clinical teams. But it's really fulfilling. I see a lot of patients still, and I don't get that many letters from patients. But I got one just 3 weeks ago from a patient, and I don't think I've ever had one from a patient saying, thank you for picking me. I saw them I was a weekend on call and said, look, you've got to do this trial. This is, if I think this works, I'd give it to you clinically. And they wrote to me and said how well they've done. It's very rare to get that as a PI, as a letter from a patient to say thank you. But I am just going to cover in the last couple of minutes patients. I was asked here, could I bring a patient here? One of the things about COPD is there's not a chance you'd get a patient of this population up here. They would struggle with the stairs, they're too breathless. The patients I'm talking about as inpatients here may rarely leave the house. So the team, and can I just say thank you to the team, recorded a patient. So I'm just going to spend a couple of minutes about a patient here.
And I was struggling to breathe, and so they'd brought me in an ambulance as in, being able to deal with that reason. And while I was there, the research doctor came out and sort of said, would you mind helping us out? And I was like, okay, how? And she explained, I said, I've done that before with COVID, so of course I will. It's great, I don't mind helping anybody who can. And that's it. I just signed up and off I went. Pretty straightforward. You just had to feed, sign, give bones, and that was it. It's been quite straightforward, easy. No. You know, what can you do? You know, at the end of the day, you're just helping somebody not harm themselves. So, I mean, obviously you think, well, you know, is this injection going to kill me? But you know, if you're in safe hands, you know that's not going to happen. And you also know that if you didn't know that. So, no, no issues whatsoever. The research doctor came to see me in hospital. She had saying what would happen. I would have this injection every once a month, and they do various tests while I'm seeing blood pressure and all that. And nothing horrible, you know. And the injection was like easy peasy. That came in and just one arm one time, and the next month it was in around 20 or painful. And that's it. There's nothing after it, no after effects or anything. It was great, you know. Well, during the study, I had to do once a month, and it had to be specific times. You couldn't go over, couldn't go under, and could go under about 7 days, and that was about it. You know, so I managed it every time. It was great. They worked around you. You know, if you got something on that day, they were absolutely fabulous. Not of them. And they take you in a taxi, blow how with a taxi, which would copy us. And we come in, and they're doing blood pressure. While they're doing that, they bring you a coffee and biscuits if you've got any. And they do all the normal to do things, heart rate, you know, to straight and not. And then at the end, once you've done, you do a little walk, and you also do like a stroke test, which basically all you do is sitting on the bone and squeezing this thing as hard as you can. And afterwards, they go for it. I mean, at the end of the day, it's getting out of your house with time. You know, you're feeling that way, you're feeling lonely. And they look after you with company biscuits. But the best thing about it is that you help somebody else. It might not do you any good, but it will help somebody else in the future. And that's why I did it, and that's why I think we should do really. Personally, I've done another one before, and so I did say pretty much yes straight away. And the doctor who came round and said, well, look, I'll give you the bombs. I'll give you time to think about it, talk to your family, whatever. And which I did, I spoke to my husband, and he said, you know, well, we're going to go for it anyway, aren't we? So I said, well, basically, yeah. So I dealt with it. I mean, the doctor came around the next day and I signed the board, and that was it. I just waited to sort of be told when I was in, really. Yeah, definitely, 100%. You know, you can't not go for it. It's so important.
So that was Judith who gave a brilliant talk, and I think she really highlighted a few things. I just highlight the few forms thing. It was exactly right. We developed a grab sheet on the information sheet. There's no way they could get through the usual GDPR bits of reading. They were confused. So we absolutely had a grab sheet for it. So we can do it. And this, I think, acute care research, inpatient research, which COVID did show us, can have massive implications both to common patients and the NHS. So the impact is potentially huge, but we've got to be pragmatic about it. And I just want to say thank you, because the team was massive. The day we had our last patient, I emailed 36 members of staff to say thank you for being part of it. So this isn't a small group. This is a large group, but being flexible so they will work on other studies taking part on it. So I will finish there and say thank you.
That's great, thank you. We only have time for one question, so I'm going to go with, my nana had COPD but never smoked. She worked in a laundry service in the 50s. Do you find the stigma of COPD as smoker's condition impacts awareness and treatment?
Completely. And as someone who sees people every week with COPD, it is a hidden condition. We're all into celebrities, apparently, these days. How many celebrities can you name with COPD? It's the third biggest cause of death in the world, yet how many people can we name who've had it? I can name one, that was Spock. He died of COPD. There are others, but we're not allowed to. They don't advertise it, so the stigma is awful. And I don't understand why smoking is a highly addictive thing that was normal to do years ago, yet we somehow stigmatise it. We don't stigmatise myocardial infarction and heart disease, yet smoking's the biggest risk factor for that. We don't stigmatise other things. Something about COPD sticks, and I don't. It'll never be sexy, but that's why I want to champion it and say, look, we've got to do it.
Thank you very much.